Hello and welcome to Talking Meds, a podcast from PrescQIPP, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at PrescQIPP. Hello and welcome to the latest episode of Talking Meds, where I'm joined today by Prof Sailesh Mishra, and we're going to be talking about the vexing topic of pain management. Sailesh is a consultant in pain management and anaesthesia at the RVI in Newcastle, my hometown. He started his medical career in 1991, qualified as a doctor in 1997, and started his journey as an anaesthetic and pain management doctor in 1998. His field of interest in pain management includes acute and perioperative pain, neuropathic pain, and the rational, safe prescribing of opioids, something we're all really interested in and knowing much more about. It's a really tricky topic. He works on many national pain groups, including at the British Pain Society. But interestingly, listeners, beyond his role as a doctor, he's a radio presenter and is known as RJ Sailesh and has a weekly live radio show that goes from the local FM radio station Spice FM to all over the world to thousands and thousands of listeners. And the topic he talks about is Bollywood movies and it's called Bollywood and Beyond. So if you're interested in that, have a listen, 7 o'clock on a Friday evening to RJ Sailesh. Sailesh, welcome. Thanks very much for joining us today. How are you doing?
Thank you, Jonathan. Thank you for that lovely introduction, and thank you for having me on your show.
Absolutely. So, I mean, obviously, pain management is something that we all struggle with, either as a person, have personal experience of it, whether it's friends and relatives or as clinicians. It's a really difficult topic. So, just in terms of your background, then. I mean, I mentioned a little bit about your background, but what was it that brought you to working in the role of pain management?
That's a lovely question. So basically, in the UK, most of the pain doctors come from an anesthetic background. So I did my anesthetic training, and then I finished that in India, then came over here, went through retraining here, and then finished my fellowship exam. And then you reach a stage in your life in the middle of the training where you think of branching into either intensive care or neuroanesthesia, pediatric anesthesia, or pain management. Those are the things that were kind of most common that time. So when I was thinking of choosing a subspecialty, and then one of the questions was asked to me is that, what is it that your friends would tell about you? And then I thought, there was a moment of reflection, and I thought probably they would say that if they tell me something in confidence, I would keep that with me, and that they would feel confident enough to share their kind of issues with me. And one of my mentor, I want to just go on air saying that Dr. Debbie Nolan, who was high up in the Royal College of Anesthetists, she then said, okay, actually, you know what, Sailesh, why don't you think of pain as a career? Because I think that is a very much an essential quality, almost so to say. So looking back, I have enjoyed doing this job for a living, and it's become a part of who I am now. And so yes, listening to people, giving them an overview, giving them some options that there are things still available for you to be involved in your own decision making. That is what I feel pain management is all about.
Yeah, I mean, pain is a really subjective topic that feels different for different people. There's no one way of describing how pain feels, and we use lots of different scales where we try and get a bit more objectivity around the subjectivity of the feeling of pain. And that obviously makes it quite a difficult thing to manage, doesn't it? Because you have to listen to the person and believe the person when they tell you they're in pain, don't you?
Absolutely.
And that I guess that can be quite a challenge. So as well as that, what are the other particular challenges around your role?
So as a chronic pain management doctor, you are faced with few challenges related to the patient itself, challenges that the system poses to you, which you try to work towards the best of your ability, and then challenges about your own thing. So patient challenges could be actually where they are coming from. So how long they have lived in this pain. Where is the pain? Is it something that is probably fixable with some medical or non-medical intervention, or is it something that probably needs a more wider assessment of helping them come to manage this pain? Because if truth is to be told, we are talking more about managing rather than curing. So the one key difference is somewhere in that patient journey, helping them to understand that actually we are talking about control rather than cure. And sometimes if people have already got it, by the time they're coming to the clinic, that's easier. Sometimes when people are looking for a fix for a pain that they have been living with for 20, 30, 40 years, that's a bit difficult. But slowly with interaction and with signposting to correct services, that is achievable. So that is one challenge. Pain and social deprivation, unfortunately, goes hand in hand. And therefore, you find that in the areas of the country where there is social deprivation, there is addiction, and there is chronic pain is more prevalent there than other areas of the country. So, and then pain and mental health issue is also closely linked together. Pain and addiction is also closely linked together. So these are the things we try to unpick in that conversation, that actually to see that how much we are here treating pain and how much we are here treating distress or treating depression, because one has to be also mindful of your own limitations. So I would, while I would acknowledge that and I would validate that, I would also feel responsible to signpost them to the correct services. So that is the patient challenges. The system challenges are the unfortunate long waiting periods. In a lot of part of the country, pain services struggle to see people in a timely manner. So we're talking about months and months of waiting period. And then when not everybody who comes to the clinic gets an injection, but when there is a injection to be planned subsequent to the consultation, there is a further waiting period for that. So that is another thing. And then signposting to other like psychology and physiotherapy services, there is waiting period involved in that. So while NHS tries to do its best within the resources available, there is unfortunate waiting periods involved in every aspect of this. And then the other challenge is about the physician themselves, how they look at pain. Are they here as a fixer, as a somebody who, okay, you somebody living with 30 years of pain and you try to fix it in one consultation, or you are more of a moderator, more of a bit of a lifestyle physician, so to say. Sometimes I feel that I'm in that chair sitting and just listening to people, and all I'm doing is giving them some choices and hearing and validating their story. So that is the perception of the physician has a lot to do with how people find their treatment has been going. So these are the day-to-day challenges.
Yeah, I mean, again, it's that's really interesting insight that. So those kind of those three aspects, the kind of the patient-centered challenges, the system challenges, and long waiting lists. I know for pain clinics are a real challenge for people, and can be quite frustrating. I'm sure it's quite frustrating for clinicians as well as for patients. And then the clinician challenges. Yeah, I'd not really thought about that, but I guess the traditional role of clinicians is we try and fix people, or we try and fix things, don't we? We try and there's this thing that's wrong with you. If we do this, then we'll fix it. And of course, with pain management, as you just eloquently said, you can't fix it sometimes because the underlying cause is something that you can't do anything about. What you can do is try and alleviate their symptoms and their suffering a bit. But that must be quite frustrating as well, I would think, for many clinicians working in your field, that you see people who are coming back to you time and time again with chronic problems, maybe with, as you say, underlying mental health components and addiction issues, perhaps. And that must be quite frustrating for them and indeed for the clinicians, I would think.
Lovely. Yeah, I mean, so it is about what works in pain management is actually somewhere winning the trust of that person to say that actually I am in your team. I am here. I have got no magic pill, no magic bullet, no magic injection that would fix it. But I hear you loud and clear. I validate your pain, and let's work together to find ourselves in a better situation. And at the same time, sometime a little bit of goal setting is also helpful. Look here, I can do this, and this, but unfortunately, I cannot do this, and this. So therefore, a bit of common shared goal decision making. And what I understand is that the person wants to be involved in that decision making. So while you are absolutely right earlier saying that actually medicine often oscillates between two extremes. On one extreme is actually the patronizing style of medicine, where I'm the patient, you are the doctor, you decide for me. Why are you asking me? On the other side is I'm the patient, it's my body, I need to be involved. So patronizing medicine versus patient autonomy, the pendulum swings, and each individual you are trying to find which one is the right balance where does that individual sit? Whether he or she is someone who is leaning more towards you telling them what is right or wrong, or someone who is more informed and wants to be involved in the decision making. And each case by case, you take it on that basis.
Yeah, I mean, we have that as a theme almost for every conversation we have on the podcast, that sort of person-centered approach to it, finding out what particularly matters to the person. And once you've done that, and I imagine that's the same with a pain consultation, everything you do revolves around that then. And as you say, some people may well say, well, I'm not sure what to do here. Can you help me a bit more, please? And
Absolutely.
other people might say, actually, yeah, this is my decision to make. I've got different values and preferences to you. Therefore, I will make different choices to you. And it's about listening to that. So that's the sort of the general challenges. So we're interested in prescribing of medicines on this podcast largely. What
Yeah.
what are the particular challenges around prescribing of medicines for pain management then?
So I tell people that just like the chair you are sitting in has got four legs, pain management works on the principle of four P's. There is pills, which is the medicine that you want to have a chat here today, and we will do go into depth and we'll decide all that. But beyond pills, there are some procedures. Then there is a big role of physiotherapy and equally a big role of psychology. So for me, pain management is about four P's: pills, procedures, physiotherapy, and psychology. And just like to balance the chair, we need to have weight on all the four legs. Similarly, we need to have actually thought through all of these four aspects to give a wholesome pain management. Talking about pills, again, we have the challenges about in the good faith, historically, a lot of medicines were prescribed to people for year after year, and particularly the opioids as a way of managing chronic pain. And I happen to practice in the northeast of England, which is nationally an outlier in terms of very high opioid users. So, through the last 15 years of my clinical work, we have developed some credibility in kind of understanding and sort of helping nationally in setting up guidelines and helping in the rational prescribing of opioids. So, but the good news here is that a lot of this information has now gone into to primary care, into the prescribers, into the pharmacy community. And therefore, we see a lot of good works, particularly in the last 5, 6 years. So those cases of very high opioids that I used to see in maybe 2012, 2015, I'm no longer seeing them now. So opioid is one of the treatment for pain management. The other one is nerve pain medicines or the anti-neuropathics that we call. And again, lot of people would be on high dose of opioid and high dose of anti-neuropathic. And now we know that some of those anti-neuropathic end up doing more harm than good. And it's the combination of things that is more tricky. So again, in the consultation, looking into each individual group of medicine and seeing their interaction, seeing their dose, assessing their efficacy, and then discussing with the patient. That is what is the challenge on a day-to-day basis.
Yeah, and specific challenges around the use of particular medicines or particular types
Yes,
of medicine?
just to for our listeners, few things that would be in the drugs, things that will come up is that actually in 2026, long-acting opioids have no role in chronic non-cancer pain management. So I'm being specific here. We are not talking about acute pain. We are not talking about cancer pain. And even in acute pain, long-acting opioids are no longer recommended. That's come from all the international guidelines committees from different countries and organizations. So the key thing, take-home message would be long-acting opioids are out. Patches are also almost out, except for very individualized cases where people cannot observe take medicines by the oral route. And then that high dose of gabapentinoids like gabapentin, pregabalin, and opioids, they actually together put brakes in our breathing. So there is a very high risk of respiratory depression, people stopping to breathe in the middle of the night. The Canadians did a lot of big study on that to find out that. And it's a combination of things. And then we are finding that over 70 years of age, gabapentinoids are increasing the risk of fall in elderly population, breaking their hips and knees and coming to falls department. And now there has been some evidence that maybe dementia is more kind of, there's some link. I mean, it is very early probably to say in black and white, but we have to think about gabapentinoids and the risk of worsening dementia. So these are the challenges.
Yeah, I mean, we did a series of podcasts with Lucy Pollock, who's a geriatrician down in Somerset, and she was one of the things we talked about was the use of pain medicines in the elderly people, so people who are aged maybe over 70 or so, and the risk of falls within that. And she would be very, very careful about doing medication reviews in people who are on gabapentinoids and opiates, especially high dose ones. I mean, it's a difficult thing to, if you like, deprescribe. I don't particularly like that word, but to have a a person-centered conversation to try and reduce either the dose or the medicines that they're on. It's not an easy thing to do. And I don't think we
No.
can pretend to say, oh, you should just be reviewing people's medicines and stopping them. It's much more difficult than that. But there's definitely an aim there, isn't there? I think the message about chronic non-cancer pain and opioids is slowly getting out there. I was part of the guideline group at NICE when we wrote the guideline about medicines of dependence and the management of pain, and we talked about that within that. But hopefully that message is filtering out to people. But I'm sure there are still people out there who are still using long-acting opiates for chronic non-cancer pain. But again, the challenge is if somebody's been on that for 10 years or maybe 5 years or a
Exactly,
number of years,
exactly.
it's a difficult thing to do something about, isn't it?
Yeah, absolutely. So, and I tell people when I see people for the first time, and then I'm mindful that I tell them in exactly these words that look here, this is my first, this is our first interaction. So, and some of the word, some of the things that I would present to you might actually appear like, where is this coming from? But I just want you to know that actually, everything that we talk about here is I'll be only suggesting to your GP, and eventually your GP is the person who is kind of, or GP practice is the place where these changes are taking place on a kind of monthly basis or a fortnightly basis to your medicines. And therefore, my role is advisory, but I can point you to the right direction. And we're not talking about completely stopping it. We're talking about making sure that if it is worth using it at the dose we are using. And then the other analogy I would give is that, like, if we're having an infection and we are trying one antibiotic, and if it is not working, we would not just increase the same antibiotic. We would go to a different antibiotic to find the one that works. So, and it's a little bit of negotiation, and it is a bit of, and sometimes I find that we haven't probably explored the anti-neuropathics properly, and there is some option to optimize the anti-neuropathics. The other group that we probably don't use as much as we could is the anti-inflammatories, because of the classical fears of worsening gastritis, kidney disease, and all that. But the literature will tell us that actually probably we worry a bit too much than we need to. And within rationale of having a safe network, we can still prescribe on and off anti-inflammatories to help in that process of lowering opioid. So these are the things. Yeah.
Yeah, yeah. I think the point you make about anti-inflammatories is an interesting one. I think over the years we have become very fearful, a little bit cautious about the use of anti-inflammatories. But it goes back to that question: what is it that's most important to you as a person? If you are in absolutely excruciating pain on a long-term basis, that will completely dominate your life. You'll not be able to do anything else apart from worry about the fact that you're in pain. So actually, the risk of getting a GI bleed or gastritis, or perhaps getting a worsening in kidney function, or perhaps an increase in blood pressure, that for that person, having some control of their pain might be the thing that really dominates that conversation. And I think sometimes we lose perspective of that, and people will just say, "Oh, you need to stop that non-steroidal because," and actually, that might be something that's really detrimental to that person's health because their pain might come back. So it's about having again that holistic approach.
Absolutely. And you're right. And sometimes we call it as breaking the cycle. Somebody who has been in that downward spiral, and even a course of anti-inflammatory with all the precautions for 5 to 7 days to observe whether it is working or not, and are they able to tolerate it or not, that will go a long way. And for our listeners here, I mean, if we talk about medical statistics, number needed to treat, the way I put it is pain management pills are broadly in four groups. You're talking about paracetamol in a group of its own, anti-inflammatories, anti-neuropathics, and opioids. These are the four groups. And then there are some other adjuncts on and off, but these are the main four groups. Of the four groups, the most important one, the one with the best number needed to treat, is actually anti-inflammatories. We're talking about the COX-2 inhibitors having 1.9, 2.2, or maybe even the first generation anti-inflammatories 2.3, 2.5. So for every two people you give, one person is likely to have 50% pain relief. So that is how objectively we are establishing the effect of that. So, whereas opioids and antineopathics are much worse than that. So, therefore, it is worth one of the things from this podcast to our listeners would be if you think of an anti inflammatory, think of a reason why you can't give it.
I mean, again, I completely agree. It's that what is it that's important to the person here? And if, as you said, I remember when the old publication Bandolier did a load of did the comparative pain table, and non-steroidal anti-inflammatories came out with, as you say, quite a low NNT compared to some of the other pain medicines that were being used. So it's like with all things, it's about getting this in balance, isn't it? And the other thing is, I think, a very interesting thing to say is using sort of a therapeutic trial of an anti-inflammatory. So try it for a week. If there's no improvement, you know what? That's probably not the suitable medicine for you. Often, I think what happens is people get put on an anti-inflammatory and they get left on it, even though they perhaps haven't had any benefit from it. And I think that's potentially where some of the more chronic problems come from. So just to go back to, so in terms of guidance then, Salish, what guidance is there out there for people?
So, very good question. So, there is some robust guidance. The first thing to do is all the major organization, be it our MHRA in England, be it the Canadian Society of Pain Medicine, Australia and New Zealand Society, ANJCA, or US, they have all said that long-acting opioids have no place in acute pain management. So, long-actings are pretty much out in acute pain management. That's universally speaking now. The second change that has come in is that the Faculty of Pain Medicine has done a very robust work. Previously, we identified 120 milligram of oral morphine equivalent is what would be the upper label, and that was on the back of the CDC work that was done in 2016. Those works got updated with opioid aware coming into our country in about 2017, 2018, and quite a good visibility around that. And then CDC further revised it guidelines around 2022. And in these years, we have seen that actually a lot of complication happens once we cross 50 and definitely once we cross 90 milligram. So in December last year, just before Christmas, the Faculty of Pain Medicine has updated its opioid hour guidance. And now the bar has been lowered to 90 milligram. So in management of chronic non-cancer pain, we should not be using more than 90 milligram of oral morphine equivalent, and ideally not more than 50 milligram. So if we use a traffic light analogy, so of 0 to 40 milligram, we are in the green zone. 40 to 80, we are kind of 50 to 80, we are kind of in the amber zone, and more than 90 or more, we are definitely in the red zone.
Yeah, there's lots of analogies coming out in the podcast today. So our number one fan, Steve Williams, he loves an analogy. Does Steve? No, thanks for that. I think so. Building on that, and I think the other thing to say, listeners, Salish is doing a masterclass for PrescQIPP. Actually, today we're recording it. So by the time this podcast goes out, it will already have been done. So you'll be able to listen to it on catch up on the PrescQIPP website. PrescQIPP have also done a load of other resources out there that links to all of these material, all these guidance and materials that Salish has mentioned. So we'll put a link to those in the show notes, and there's lots and lots of resources out there for that. I guess my other question, and you talked about the guidance being updated. When I worked as a proper pharmacist a long time ago in a hospital, actually, the medicines that were available then are the medicines that are available now. That must be quite frustrating, I would think, for a paid consultant. So I guess my question is there anything around the corner in the future that's going to be another helpful part of our armamentarium for the management of pain?
Very good question. Yes, you're absolutely right that when I started my pain fellowship around 2008, 9, and now looking back 20 years, we haven't really got any new medicine. The duloxetine is the last one that we had, and so therefore, and then among non-pain medicine, and then tapentadol is the newest opioid we have. I have been as a PI, I have been involved in some new pain medication phase 3 trials, and the reason why it hasn't taken off that big way is because of the way our trials to be validated, the way that they are set up. It is very difficult for a person living in pain to say that you need to come off all your pain medications to then trial these medications. And then the trials are typically set for 12 weeks and then maybe some longer outcome data. So the designs is difficult to design pain trials in chronic pain patients. So that is one thing. But however, you can see that in the other aspects like neuromodulation or other invasive treatment therapies, there has been a lot of positive things that have been done, and those aspects have really taken on very nicely. However, not the medicine side. You're absolutely right.
Yeah, I think that's the thing. It's probably the non-medicines interventions for pain that are, from my reading around, is that there's a potential for serious innovation coming fairly soon. Whether it's a technology, a med tech product, or indeed there's been lots and lots of work done on sort of self-help. And we talked about the psychosocial
True.
somatic side of pain as well. There's lots that's been looked at with using sort of talking therapies that can really, really benefit people, and having access to that has always been
Absolutely.
difficult. And so, digital based
Yeah.
tools for this are really, there's some really quite innovative ones around at the moment. So yeah, so let's look forward to that. Maybe not in the medicines world, but in terms of other interventions.
Yeah.
So Sarah, this has been great. Just to finish off, can we always like to ask, what are the three things that clinicians should do to get up to speed with the different topics that we're looking at. So, what do you think the three things clinicians should be thinking about around pain management?
Right. Okay. I would say my top three from this session for our audience would be that think of the total amount of opioids they are on, and definitely limit it under 90, and ideally all of it as short-acting preparation. Now, short-acting preparation comes as tablet and solution. So if you see somebody who is probably out of desperation may swig the bottle, so probably convert them to tablet. There might be a bit of a cost implication for the primary care, but in the long term, it would be justifiable. So, and then it is not just the opioid, but the interaction with other medicines, the benzodiazepines, the other gabapentinoids, and those sort of things. They are important. And think of the anti-inflammatories. So, a course maybe to see that, because good going musculoskeletal pain, widespread arthritic pain, why not? If they have a little bit of asthma, a little bit of irritable bowel, is that a real indication not to give them a try? So, and obviously think of the PPI when they're over 50, 55 or have got other comorbidities. So that sort of thing. The other thing is to tell people that actually it is science that beyond medicines, physiotherapy, psychology have a role. And my psychology colleagues tell me to signpost people to two particular apps on the phone they can find. One is Calm and the other is Headspace. I don't have any conflict of interest to declare here, but just to say that people can use those apps. Even the free versions are good enough to kind of help them with that. And that regular review would be helpful. So if we change something and if we can review them at our pharmacy colleagues come in there, they have a very, very big role in able to offer that timely and very good review and in signposting, flagging things. So those would be my top three.
Brilliant. So, just as a reminder, so medicines, the dose of the maximum dose of opiates for chronic non-cancer pain. Have a think about that. The therapeutic trial of non-steroidal anti-inflammatories. Think about the non-medicines aspects of pain that can be really helpful, and the use of apps and things like that. And then, brilliant, regular review. I mean, that's the thing that you often see people who are just left to it for a number of months or maybe even a number of years, not getting benefit from the treatments, and then other issues develop, don't they? So that regular review thing is really, really important. So that's been brilliant, mate. I've really, really enjoyed talking to you. It's been great. I did have a listen to the radio show last Friday, actually, and I have to say I'm not a massive Bollywood fan personally, but it's a really interesting radio show. So yeah, congratulations on that.
Thank you. It is just something to tell our listeners that actually there should be one other thing beyond our work that we can find relatable. And that is sometimes very therapeutic as we go into the second half of our life. So,
That's
so
Yes,
yeah,
find something creative to do. Just like I'm hosting a podcast and you're hosting
yeah,
a radio show.
absolutely.
I mean, people might call it a midlife crisis, I say this, but I don't think so. But I think you're right. You need to find things that bring joy in your life. And actually, if
Absolutely.
you've got pain,
Yeah.
Do the things that bring joy in your life, because that's probably going to help you cope with the pain if you can't do anything about the underlying cause of it. So absolutely. Well, on that note, I think we should. Thanks very much, sir. This has been brilliant talking to you.
Thank you, Jonathan. It's been an absolute privilege, and I'm very grateful. Thank you so much.
Brilliant. Cheers, guys. See you soon. We hope you enjoyed today's podcast, and we'll see you next month for the next episode of Talking Meds from PrescQIPP, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us at talkingmeds@prescripp.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the PrescQIPP website and all our excellent resources.